All right, let's step straight into the trauma bay. In this explainer, we're executing an integrative, high-yield clinical simulation, and we've calibrated this strictly for top-tier medical mastery. We're talking that 280-plus score territory. Our focus today is blunt abdominal trauma, specifically the really delicate and honestly pretty deceptive management of splenic rupture. I mean, in this high-stakes environment, seconds literally dictate survival. Knowing the exact boundaries of operative, interventional, and conservative management, it's completely non-negotiable. So we're going to lock down the intricate mechanisms, the discrete management steps, the dangerous traps, and those critical exceptions.
Okay, let's dive into this first major concept. When a patient rolls in following severe blunt trauma, the absolute first operative trigger you're looking for is hemodynamic collapse. We're talking about a systolic blood pressure under 90 alongside profound tachycardia. If you start IV fluid resuscitation and that patient is just entirely unresponsive, and your ultrasound shows free intraperitoneal fluid, there is absolutely no debate. The absolute medical mandate is an emergent exploratory laparotomy. You strictly bypass all CT imaging. Seriously, moving a hemodynamically crashed patient to the CT scanner is a fatal error. It will cost the patient their life.
To really grasp the mechanism driving this collapse, you've probably seen this before. Just picture the classic abdominal seatbelt sign in a restrained driver. It's a massive, high-yield external marker of the blunt trauma cascade. And when you're analyzing this cascade, you absolutely must remember one vital statistic. The spleen is the single most frequently injured solid organ in blunt abdominal trauma. The massive kinetic forces transferred right through the abdominal wall directly shear that highly vascular splenic parenchyma. That anatomic disruption leads to rapid, massive hemoperitoneum, which, as you'd expect, drives that profound hemodynamic instability we just talked about.
Let's lock down the precise sequence of assessment here. Step 1, rapidly recognize that blunt trauma mechanism. Step 2, get your immediate hemodynamic assessment. If that assessment reveals a hypotensive, unstable patient, well, Step 3 is absolute. It's the FAST exam, the focused assessment with sonography for trauma. This is the absolute first diagnostic step in a hypotensive trauma patient. It rapidly and non-invasively interrogates the abdomen for free fluid, and that dictates your very next maneuver.
We really have to starkly separate our management algorithms here based purely on the patient's physiology. For the unstable, fluid-unresponsive patient like we just established, you strictly bypass all advanced imaging and route them directly to the OR. But in stark contrast, we have a totally different scenario, the hemodynamically stable patient, or the one who immediately and sustainably normalizes after you give them initial fluids. For these stable patients, the strict mandate is to pass them right through the CT gateway. You must get a CT of the abdomen and pelvis with IV contrast to definitively grade the solid organ injury.
Now, what's really interesting here is the critical radiographic trap that happens once your stable patient safely passes through that CT gateway. You might easily spot a splenic laceration, but the ultimate discriminator in your management is the presence or absence of an arterial leak. On the scan, this looks like a hyperdense pool of active contrast extravasation. In the trauma bay, we commonly call this a blush. And listen, this blush is not a benign or incidental finding. No way. It strictly portends a catastrophic delayed rupture.
The mandate here is absolute. Even if your trauma patient is sitting there in the bay with completely normal, perfectly stable vital signs, an active blush on the CT scan dictates immediate, proactive intervention. You absolutely do not wait for them to crash. The strict medical mandate is splenic artery embolization, or SAE, performed via interventional radiology to proactively occlude that bleeding vessel. Their current physiologic stability, it's completely irrelevant to this specific intervention.
But we need to contrast that embolization mandate with our strict non-operative management baseline. What happens if the CT shows a low-grade splenic tear, the patient is completely stable, and there is absolutely zero evidence of a contrast blush? Well, in this very specific scenario, the mandate shifts back to observation. This means strict, conservative care. You admit them to the ICU, get continuous hemodynamic monitoring going, perform serial abdominal exams, and aggressively track those serial hemoglobin levels. This brilliantly illustrates the crucial dividing line in trauma management. Notice how the exact same radiographic finding, a positive FAST exam showing free fluid, diverges into two entirely different mandates based solely on fluid responsiveness and vitals. Positive FAST plus unstable vitals strictly requires the operating room. Positive FAST plus stable vitals strictly requires the CT scanner. You've got to lock this clinical variance firmly into your framework. It's tested relentlessly, and more importantly, it's executed daily in real practice. Okay, let's shift gears for a second. If conservative or interventional management fails, or if the initial trauma is just too severe to repair, you're forced into an open splenectomy. But taking out the spleen introduces a severe, non-negotiable immunologic trade-off. The patient immediately loses massive numbers of splenic macrophages, which filter opsonized pathogens from the blood, and they lose a critical reservoir of IgM-producing B cells. This sudden deficit creates a severe, lifelong risk for overwhelming post-splenectomy sepsis, which is primarily driven by encapsulated organisms. Because of this encapsulated threat, a strict vaccine timeline is absolutely mandated. These patients must be vaccinated against Streptococcus pneumoniae, Neisseria meningitis, and Haemophilus influenza type B. Now, to make sure they mount an adequate, robust immune response, these vaccines must strictly be administered either greater than 14 days prior to an elective splenectomy, or, since we're talking about unexpected trauma here, strictly greater than 14 days post-operatively. On top of that, daily oral penicillin prophylaxis is typically mandated for 3 to 5 years post-op, just to bridge any gaps in immunity.
All right, let's see how this all builds into our master case. We're going to test your deep integration of these critical thresholds. Here is the structural blueprint. You've got a 22-year-old male brought into the bay following a high-velocity motorcycle crash. His initial blood pressure is perfectly stable at 115/75. Heart rate is 95. Fast exam is positive, shows a small amount of fluid in the splenorenal recess. The subsequent CT confirms a grade 3 splenic laceration. But crucially, it reveals a bright expanding pool of hyperdense contrast, a blush, right there in the splenic parenchyma. Again, vitals remain perfectly stable. So what is the definitive next step in management?
Here are your 5 distinct, highly competitive answer choices simulating actual exam conditions. This matrix is designed as an aggressive diagnostic trap. Those perfectly stable vital signs, they are engineered to heavily tempt you into picking conservative ICU observation. On the flip side, that grade 3 tear is placed there to tempt you into immediate aggressive open surgery. You have to navigate these deceptive clinical markers meticulously to land on the single correct mandate.
Let's execute an exhaustive choice-by-choice breakdown. Option A, observation, is a fatal trap. Sure, the vitals are stable now, but that blush tells you catastrophic failure is impending. Options C and E, laparotomy or open splenectomy, also incorrect. The patient is currently hemodynamically stable, so immediate open surgery is overly aggressive and entirely unnecessary right at this exact moment. Option D is an archaic diagnostic tool that's been completely superseded by FAST and CT. So the top-tier clinician must definitively map that active contrast blush directly to an active arterial leak and forcefully select option B, splenic artery embolization. You strictly bypass both pure observation and open laparotomy.
In the incredibly high-stakes environment of trauma surgery, stability is, very often, a deceptive illusion that's just masking the next physiologic collapse. Relying strictly on a blood pressure cuff while ignoring the absolute radiographic markers of impending hemorrhage will cost lives. The clinical pathways we covered today are strict. Unstable goes directly to the OR, stable goes to the CT scanner, and an active blush mandates prompt embolization. So the question you have to ask yourself on your next trauma shift is this: will you catch the blush before the break?